the word value is bringing more problems than solutions, because at certain moments we are trying to look for the perspective of value, and the value that we are getting to located value. So the different perspectives are something that we need to be taught and need to know exactly what's the perspective of value, that because they are leading to a lot of changes. And the technical value is sometimes what people are talking. For example, when we talk about economics, we are just talking to monetary and technical approaches, but sometimes we have to have a broader approach when we are talking about value. And the word, sometimes it makes a lot of confusion because people are talking about quality, but they are being misconfused about the word value and quality. And it's a very different thing, because quality is bringing some not such much incremental solutions, and they have been having limited impact concerning even what's costs and what's the outcomes for the patient. So don't misunderstood the word value over quality. But first of all, sometimes we are talking about a great movie like Star Wars, but we need a more elementary vision when we are talking about the implementation of value-based healthcare. And that brings Lego. Lego means play well. So in practice, sometimes, as you're going to see, we need a more elementary and more discriminative approach when we need to implement value-based healthcare. And it's a little bit this saga, when you're looking to the clinical pathway of the patient or the patient journey, sometimes it's a little bit like the Obi-Wan Kenobi story. If you see, they are not on the beginning of the story, but you have to catch and to see the whole idea for you to understand the movie and the saga, to try to understand what's the patient journey that you got and the vision that you shouldn't be just looking to one specific moment when you are doing value-based healthcare. So healthcare is bringing a lot of challenges. We don't need to create more challenges than the disruption that we are creating nowadays are having. We are going to have normally an increase of aging of the population. We'll have an exponential increase of the prevalence of chronic diseases and multimorbidity. We'll have an increase of complexity of care. So it's normal that we are going to spend more to achieve more outcomes for the patient, but mainly we should not be looking to a volume approach. We should be looking to a value approach. Why? Because it's so much important to be measuring correctly what we are doing. And of course, we have the digital disruption that needs to be fulfilled and needs to be looking to what we are creating. We have been looking for these slides for a long time. The truth and honesty is that we are not creating so much richness, so much money on the way that we are delivering healthcare. We are wasting and getting a lot of expenditure concerning the product that we are developing for internal GDP. It's not only on Portugal, it's all over the world. And why? One of the major things is because we have high variation of behavior, high variation of outcomes, but it's mandatory to control this variation approach. If we look at cancer, for example, we see that's a huge transformation concerning mortality, concerning duration of the treatments, improvements, and even target therapies that we are creating nowadays. For example, cancer is being progressively redefined in the last 20 years. So you have a lot of innovation that you need to create better outcomes for the patients. But we know that we have so much huge inefficiency all over the world. And this is a study from Ernst & Young that is showing that the waste goes up to $1 trillion. Why? Because we have huge variation and we have huge duplication and even errors on the model of pathway that we are creating. So there's a huge capability of improving efficiency the way that we are delivering. Why? First of all, we have to question ourselves, healthcare is an art or a science? Because at certain moments, if it's a science, it should be measured, and not looking for a specific methodology that everyone should do whatever they want and whenever they are doing to have this huge variability. Because the variability is contributing to high expenditure on healthcare. I always start because healthcare and talking about in outcomes is a little bit like a bucket of tomatoes, you know. And the difference is between knowledge and wisdom. Knowledge is knowing that tomato is a fruit. Wisdom is not putting into a fruit salad. And we are been talking about measuring outcomes and putting everything in a bucket of tomatoes and saying that we are talking about quality and talking about defining the best outcomes. It's not true. We don't know what's the discrete moment that we are able of differentiating by pathology what we are achieving. So what's the value of the gestes produced along with the chain for a given disease? What is that kind of value? At the moment, we are only predicting the volume and the payment for that kind of volume. But it's mandatory to know that, for example, in Portugal, just a glimpse of what's Portugal, it's a 10 million citizens, mainly a national healthcare service with tax supportive system, with 11% of the way the expenditure on healthcare concerning GDP. Now the private system goes up to 39% of the access, and we are shifting from the model of volume to a payment of value. I can tell you a story like in Star Wars. Once upon a time, you know, there was an emerging shift on paradigm of evolution of the economical values, you know, and the models of economical models. And these economical models should lead to a reduction of healthcare expenditure. But it's much important to create a balance on the ecosystem. This is another important message. We are not creating a balance on the ecosystem of each of the stakeholders. And that's a very important thing that we should be looking for. Why we are creating this unbalanced work, because this has a relationship directly what's the struggling of implementation of the value chain. So in Portugal, we are facing a growing challenge. There has been for a long time a lack of strategies based on value creation model, and the focus is too much on the blind mechanism of expenditure control. The first big important thing when you are dealing with value-based healthcare is to reduce what I call the cognitive dissonance. You know, we should not be looking to blind mechanisms of controlling expenditure. We should be creating really value chain, and we should be creating better outcomes that matter to the patient to the correct cost to deliver that outcomes. But I will increase another thing that is very important: the cost to deliver these outcomes with the lowest variation of the behavior, because we are seeing a correct correlation with the variation of behavior, with the variation of costs, with a direct variation of an outcome. And then we ended a little bit like this road game between all the stakeholders. It's an opposite forces of cost reduction. And this creates an unbalanced ecosystem in the healthcare. And if we look to decision making and the high variability that we have, we know by sure that the average compliance of the best practice and the compliance to the guidelines are something that makes us a big question mark. Because we talk about medicine based on evidence, but then when we start looking to the results, we have very different kind of variability on the way we are getting this compliance. And this is the kind of numbers that we can get on the waste that we are delivering, costs of inefficiency. And why? How people pick up healthcare, how patients decide healthcare. And they are mainly based on perceptions, not based on reality and evidence. And this, my fellow pigeons here, they always bring up this talk to an important thing, is how we can share decision making, how we are doing decisions among healthcare. And I always bring Einstein, you know, because it's the principle of insanity. We have been talking about getting different results, but having always the same methodology. How can we get value-based healthcare if we're just shooting for volume, if we are looking for perceptions of healthcare and not controlling the variation of behaviors of the things that are happening, and not knowing if you are putting tomatoes in a salad fruit and talking about measurement of quality. So that's why I think, and that's why it's came so much importance, the concept of value-based healthcare that was brought by Michael Porter. And it doesn't need to be shown the importance of the mentality to create better outcomes with the best costs to deliver that outcomes with the less variation, delivering value. This was the publication that really brought a lot of to the science. I'm not going to be very hard on that. But the thing is that if you look to literature, there's a lot of publication showing organization and IPU, talking about outcomes and costs, talking about IT. But when we start looking to the whole value chain and the other aspects and the interaction of the value chain, then you start having a lot of problems, you know. But that's why it's important for us to think if the methodology that we are using is the correct methodology to achieve that result of value-based healthcare. Then we can compare apples with apples. Then we can compare what we are really measuring, because nowadays we don't have that possibility to be so much independent on the analysis. So value-based healthcare is a huge opportunity. And the $1 million question is that where to start? Who for whom? What's the role of the stakeholders? Are there enough solutions applied? What's the golden formula to prove that putting value-based healthcare in practice is a way that we can achieve and really have that evidence? So I went back to the Stone Age, and they were already talking about value-based healthcare. They were talking about the value analysis to achieve. So it isn't anything new, you know, but we should really align what's the perspective and the objective of the outcomes that we are delivering. At the moment, Luz Saúde is the more experienced implementation of value-based healthcare in Portugal. We have, this is my great team, which I'm very happy to show you. I have three main big spies, you know. One is typically from Russia and the other two are from Portugal. Then they have typically objectives. One is more dedicated to the clinical data analysis. Pedro that is going to talk to you about that. And it has this kind of translation between costs and management approach up to value. And then I have now Alex, which is a new guy that only looks to benchmark analysis, international benchmark, which is a very important thing. We have more than 40 pathologies going around value-based healthcare. So we don't need to be talking about the reality of implementation. The numbers show what we are doing and what we are bringing up to you with some results, okay? How can we implement this? That was one of the things that Rick asked us. How can we do that? First, we have to do a really clinical and cultural organization transformation to create this understood of the behavior and the attitudes. So we should reduce the cognitive dissonance. And literature isn't any robust about this thing. Secondly, we should have a strategy that will maximize the potential of value-based healthcare and not potentially the profit or the value or the volume that we are creating. So we should really disaggregate that kind of mentality, or else it doesn't happen. And then we should shift the focus from volume to value, internalize on the mission of the organization that we really should look to improve processes and improve efficiency to deliver a patient-focused strategy on the way that we are having this kind of approach. And this created us a huge of challenges. And I brought Cameron and Quinn saying that the most obvious manifestation of culture is the explicit behavior of the manager of the culture. So we should think why value-based healthcare isn't working and it's not easy to implement. And that was a big question on all my research when I was looking to that. First of all, we are dealing for more than a decade of value-based healthcare. And the first big mistake is that people on operation are wanting to build a Tesla using the model of value-based healthcare, and they forgot that they need to crawl before they run the marathon. And that is an important thing. People should be prepared to give the minimal viable products, the way that they are building and the way that they are creating this kind of experience. And one of the things, what is about the patients? The patients are not being on the centric approach. They are not being really as a stakeholder important. They are always behind the scenes in this reality. So what kind of stakeholders do you want to be in this value chain? This is always a question that I ask for all the stakeholders seated on the same table. And I remember that Porter described the value chain, not for healthcare, in 1985. So it was not on 2006, it was on 1985. So it's a long time that the validation of the value chain is being on the market. But one important thing, a bad system will always beat a good person. And this is very important. Why? I found very interesting the word that Darth Vader said, that I find your lack of faith disturbing. And this is what I get when we start implementing value-based healthcare concerning the teams that we have. So one major conclusion that I want to give before I pass to my colleagues is that the focus on value is a result on variation of costs. So the focus should be on value with a result on variation of costs, and not the focus on the costs, with hoping that the value will improve. So one big important message already for you to take home: be careful about the ontology of value. Be careful about the epistemology of value. Be careful about the semantics that you use for you not to create confusions, then solutions. Second, we are in the perfect storm. We have a rupture of the system that has high variation, high expenditure. So it's now the mandatory approach for outcomes and costs. And for us to sail safe in troubled water, we should start by what you are, not what it's supposed to be. So use the methodology looking for what you are at the moment, not what you think you are going to be. Because you need to have a very important team when you work with you, a very large team, robust structure, a good team looking for the champions, looking for a top-bottom approach with the board, looking for a bottom-up approach when you're getting everyone on board. And I always, with my team, use this question: so what? What's next? Start by why, you know? Because you have the data, you have the results, and so what? What you're going to do next with this kind of data? What are you going to do with this? Always remember that the evidence is different for perception, and we are having a lot of perception on healthcare like this orange. The sky is the limit, and leading the change is an important thing, but you're selling the dream with the boots on the ground. So put your team with the boots on the ground, knowing what they are, not what they're supposed to be. So one important thing that mostly people don't talk, but I wanted to bring it to you, and it's the main thing that creates a roadblock, is the culture organization. People are used to do the same things all over again, but they don't question why they are doing things. And this is an important thing because this is a resistance to change. The cultural paradigm is a resistance to change, and it's something that we need to be looking. Where to start? By volume, with the correct champions, the pathology that creates impact. Sometimes we feel a little like this kitten that is going among these huge dogs that are going to bite us. But we know that culture eats strategy for breakfast. So be aware of the culture that you have in organization. And I remember that Thomas Lee and Toby Cosgrove, when things were happening concerning value-based healthcare, were already publishing things saying, be aware that we have to engage the doctors in this healthcare revolution, or else you'll have a problem. And I remember Ian from Erasmus saying, look, in 2009, some issues of value-based healthcare are cultural change, are education, and research on value-based healthcare. These are three main problems, but no one is talking about it. So one of the things that I made on my research was how can we or can make the correct to implement value-based healthcare in the correct way of approach, because we're not just changing the environment, we are changing the social norms internally and the behavior. So I ran a study concerning, which I call the road to nowhere, where I have made an assessment concerning the impact and relevance about what could be the perspective that can create a huge blockage, okay? And this was before implementing value-based healthcare. Everyone was worried about IT. Everyone was worried about resistance to change, but they were not giving so much relevance to that, you know? Relevance was to IT, looked at the culture organizational value was not having so much impact and relevance, and the teamwork was broadly low. People were very worried about the power. Yes, they were very worried about the power because the medical art and the science is something that I have my results, okay? Look what happened when we implement value-based healthcare. It happened this. Magically, the impact and relevance of this kind, resistance to change, higher level, culture organizational value, high impact, but high relevance, leadership. And one important thing that everyone is not talking, it's about education and knowledge among value-based healthcare. So this was for me an important subject because when we entered, like I call it, the Icarus paradox, attention to the Icarus paradox, because you can be flying next to the sun and burn your wings if you're not putting your team correctly to get this kind of worry about people, worried about process, worries about outcome evaluation organization. And I found a very interesting paper about Gillespie and Dietz that says that organizational failure are not because of an external governance approach or external reputation. They fail because of lack of leadership, lack of culture, lack of strategy, lack of structures, policies, and processes. So this was, for me, a huge finding of something that people are talking behind the curtains, why value-based healthcare is failing, but they are not analyzing correctly. So I use this methodology of change. I don't use a map anymore. I use ways to take my teams to approach and know what they are doing. So I use different strategies like transformatory strategy, participatory strategy, and enforcing strategies for us to deliver and to lead the teams. Just quick examples for you to know the instruments that I use to know how can lead the team. Examples, Cameron and Queen, they wanted to implement value-based healthcare. So external, internal. They were very worried and say, I want to publish everything externally. I want to show my results before they knew their results. And I say, wait, probably it's better for you to look for the results first and then saying that you're the better of the world. What happened after they looked to the results? Oh, better is to analyze and know why the results are these and why I need to be looking internally first before I talk further outside. This is a model of measuring the culture organization from Cameron Queen. And for example, high reliability organizations, worried about the fail, difference about the companies before value-based healthcare. They were not worried about the fail. They were not sensitive to operation, reluctance to simplify. Look what happened after. Much more worried about the failure, much more depth to competence. But look of the reporting culture, of the flexible culture and the learning culture, much more higher after they start implementing value-based healthcare and knowing what's the methodology correct to use it and use the correct strategy. I'm not going to be very high intensive on that, but commitment effective was better after implementing value-based healthcare. And the diagnosis of team of the culture, as you can see, really improved. Direction, conflicts, the innovation, communication, delegation, quality, evaluation of performance, team spirit, and commitment was directly related. And you can see organizational learning like psychological safety, information experimentation, time to reflect, huge, and time to analyze, which is important for organizations to know. Always I ask these questions to my team. Who, what, when, where, and why? Who is doing what, at what time? When are they doing? Where are they doing? And why they are doing? That's why we need the clinical pathways, and that's why we need the protocols to answer simply these questions. But remember that in leading through a value-based healthcare, we have to work as a team of teams. So it's important to have these important steps to develop a plan, to create simple rules, to create a communication of 360 and enable empowered execution. Going to be quickly, remember that we are no longer in a complex organization. We are not in a bureaucratic organization. We are in a more agile, holocratic organization. But the rules of engagement are very important. We have to have trust. We have to have a shared consciousness. We have to have a common purpose among each other, and we have to have an empowered execution. It's very important to create simple rules when we are achieving and putting in practice value-based healthcare, and always have a communication cycle where everyone should know what to do when they are doing, and we are capable of creating a transparent world when we are empowering the target to deliver better outcomes for the patient. And what about leadership? We always have to be with the teams saying, I always use this terminology of leading like a garden. We have to break up the soil, plant the seeds with the right placement. So let the outcomes appear correctly and the cost. So for us to be looking for the correct objective and give time for people to reflect about what's happening. Always remember now that value-based healthcare will have a broadly approach concerning social determination of healthcare. COVID brought us a lot of challenges, but focus on what matters, which is the patient. And sometimes people forget about what's our mission in healthcare. It's to deliver better outcomes for the patient at the correct costs. So we are in a living organism, which is our healthcare organizations. We need to have one mission, but remember that organizational culture can be a poison or can be a therapeutic. If you have the correct organizational culture, you can be therapeutic on the way to that you're delivering, or else it can be very harmful. And the truth has no answer. So for you to give a leap to action, you should look what's happening, structure of data. That's why I'm passing over the message here to Pedro to talk about this, to talk about data.
So, hello everyone, good morning. So with me, we'll just dive into the numerator part of this relation. So into the part of health outcomes that matter to patients. And I really wanted to start with this. So usually when people want to implement value-based healthcare, they start in this point, what to measure. I wanted to bring here this important note. There are existing standard sets for different pathologies. The thing is that usually they have some problems. They cover limited pathologies. They are not applicable to every type of institution or organization. Sometimes they are not fully updated. Some of these standard sets were done like 5 years ago. In oncology, that's a lot. And other thing is the lack of guidance on what to do with the results after this. So usually these standard sets only give some introduction to what to measure. So I always say this, if you have the possibility, you should develop your own standard sets. In this slide, we have an example of the standard set that we developed for back pain surgery. And to start diving into the data, and as I said, regarding to outcomes, it's very important to know what to measure. But more important to that is the fuel that will allow you to get to this value, because the value is here, is in outcomes, in this case, the innovation. But you need the fuel, you need the data. And it's important when starting to know where your organization is, what's the maturity level where you are. Are you just starting to measure some things, or do you have all data stack, all data systems in place? This is very, very important because it will help you to adjust your expectations, and it will help you to also adjust what you can measure and the expectations of everyone involved. And also this thing about, because everyone now talks about doing machine learning, doing using AI, and I will talk about this a bit further. But it's important to know what type of things are you doing? What do you want to do with your data? Do you want to do descriptive analysis like common data analytics, or do you want to create predictive models? So know what you are doing and what your main objective is. So about healthcare data, I wanted really to bring this here because with this question, like, can we sleep well? Because usually people think like that healthcare is very advanced in what's concerning with data, and in reality, our expectations don't have nothing to do with reality, because in healthcare, unstructured data represents almost 80% of data, and this is a very recent report of Accenture. And just understand that data in healthcare is also growing very, very, very fast. So it went from 153 exabytes in 13 to more than 2000 in 2020. So if this unstructured data is always there, and if we don't do nothing, it will continue to grow. And this is a big problem. This is something that we try to address in the ways that we think of the electronic medical record. And here you see an example of our tumor board evaluation in our EMR. So we can extract all information here in structured fields. Also, an important thing is risk certification in identifying possible confounding factors. So when you're measuring outcomes, it's important that you assure that you collect all possible information on baseline. We have integrated the PPOSM score, for example, for surgical pathologies, and we also, and I put here the example of our correlation metrics for endometriosis. This is a way of identifying possible confounding factors so that you can really ensure that you're comparing apples with apples, and instead not comparing apples with bananas, for example. And after all this, so we define what you want to measure, we have a risk certification strategy, and now another thing. How are we going to assure that we are capturing all the patients that we want to capture? So the thing about semantics is very important, because currently there are a lot of different semantic databases. Like probably majority of you know ICD-10, but there's also SNOMED-CT, there's LOINC, there's ETC, there's national codes. So how to deal with this? And I think that this topic of interoperability, it's very important, because you need to know the type and the characteristics of the classification system that you're using. For example, SNOMED-CT is a terming system designed from end-to-end use. And ICD-10, it's only a statistical and hierarchical classification. So this is important. Also, the thing with mapping. If you're doing outcome analysis, you need to know that you can map all the classifications that you use. If you're capturing something in SNOMED and then you have other data in ICD-10, you need to know that you will be able to map it. Also, language, querying, and cost are very important. In reality, we have been involved in the EDEN project, is a EU project of semantic interoperability that will assure the possibility of comparing and getting a common data space in the European Union, and also OMOP. It's also a different project. And just to be quick here, don't become lost in translation. Always ensure that when you start these kind of projects, you know what kind of data you're using and that you have a mapping system in place. I give you the example of SNOMED International. They have in their GitHub some solutions that are ready to almost out of the box to assure conversion at least to ICD-10. So always ensure that you have these systems in place. And as Filipe said, it's better to crawl first. So I here give a very simple process, and the points that we always follow when we are doing this. First, with the doctors, you know the variables that we will collect to answer that outcomes. You need to map them to corresponding fields in EMR. After that, it's very important to not jump to data extraction. Before, you need to do a manual sample. to really know the pattern of feeling of doctors. You need to know if they are feeling that those fields that you identified, if they are feeling the information there. And after that, you need to reassess your first map so that you can have a complete and real mapping of all these variables and the information. And the last point, don't forget to consider for exceptions and for possible changes that occurred in the EMR. For example, if you're saying that you're measuring something between 2015 and 2020, assure that the EMR system didn't change during this period. So all your data will be have missing data there, and it's an important topic. Just to give a quick example, this is one of our data models. Don't fall into the many-to-many relationships. It's a very hard trap to then escape from. Here it's an example of our dashboard of hip surgery. We always do this baseline certification and also some of our results for surgery in spine. And this is our benchmark in cataract. So we always compare this with international registers, literature. So you should also do the same so you can have a better idea of what's your positioning. In this case, we can, for example, compare ourselves to the ERECU register or the Sweden register, and we can notice that we are in a good position. So this is very important. To sum this part, and to reach the moon, as I say here, these are the 4 simple steps. So you first define the outcomes with the clinical theme that you're working with. You need to query the data and analyze it, dashboard and make it publicly available so the doctors can act upon it. And this last point, I really wanted to give a special focus to this, because if possible, your main objective should be to automate this, because the value-based healthcare theme and everyone involved should somehow move from this data analysis to other tasks. So if possible, you should always want to work to automate this. And using a full data stack, this is the one we use with Python, Anaconda, Streamlit, Power BI, and VS Code. It will improve and make it possible to do this in a more fast way, and to also do some statistical testing. Now, I will talk a bit about machine learning and natural language processing, because everyone is talking about this. And I always get the feeling that in reality, people are just, the majority of the community are just this rabbit here. Because the companies usually put the carrot in front, and people just get a bit hyped about it. So there's a lot of buzz regarding this. And of course, machine learning is important. It has its own place. And we implemented some and developed some machine learning models. You should always follow these steps. You know, there's a lot of steps here. And now I really wanted to get to that last point, the explainable and transparent models, because now there's a trend regarding to explainable AI and ethical AI. When you build a machine learning model, it should not be a black box. You should be able to present it to everyone and say, look, the machine learning model works like this. It's giving this feature this importance, etc. So don't forget this point. It's really important. And here are some of the examples when we used machine learning. So we used it to create clustering in endometriosis. So we did a multi-correspondence analysis and then a K-means clustering algorithm. So we can have clusters of patients that have the same characteristics, and then we can use to build a predictive model. And also, if you don't need to have all this technology, even Power BI gives you this logistic machine learning model in the insights package that allows us, for example, to understand that an anterior surgical approach has a better result regarding to mobility. So this is very important. Also about natural language processing, because usually when people say, look, you don't need to increase structured data because now we will deep dive into the open text fields, and with NLP we'll get all the information. This is somehow true. The thing is that even if NLP has a lot of possibilities in healthcare, and it's a developing field, there's a lot of limitations also. The pre-trained models usually lack accuracy for specific fields like healthcare, and also the training of those models takes a lot of time. Just to give you an example, the training of a good NLP model usually requires like 1 million data entries. So this is very important, and they have to be annotated manually. So it's important to have this idea that NLP still has some important limitations. And to give you an example, we're starting to work on this. This is our own model that we are building now. So it's in Portuguese, but I will translate to you. I'm just writing that the patient is bad, is doing therapeutics with osimertinib for lung cancer, did a CT scan today, and that currently has diarrhea. And this model identifies all these points like the CT, the therapeutics, the state of the. Now, to talk a bit about clinical pathways, because clinical pathways, as Filipe said, are very important. They are a tool that somehow helps in implementing value-based healthcare. But there's a very important but here, is that for you to ensure that they really contribute to improve these outcomes, these results, you need to have a process mining in place. And why? Because you need to start moving from the ideal and going to the reality. First, you need to know what are really the patients doing. And you can see here, each one of these dots is one patient. We can see in real time, and this is our pathway in endometriosis. We can see here really what's happening with these patients. So we use this inductive visual mining algorithm that helps us understanding this. And also the conformance checking, because when you say that you implemented the clinical pathway, the big question is, how do you assure that that pathway is being followed? And this is really important, because if you don't do conformance checking in form that we developed in place, the trace fitness is just 0.45. So we're just saying that from the pathway that was designed, only 45% of the patients are following it. So this is really important. And you should always do the composition analysis, because you need to understand which activities are really being done or not. In this case, the purple ones are skipped activities and the yellow ones are inserted activities. So don't forget to, after this, do the composition analysis so that you can act upon it, okay? Also about the social work. Why is this important? Here you see all these big network dots is just one person, one healthcare professional, and this helps you to identify which healthcare professional, and also if your pathway and what's happening to the patients is really a broad activity, or if it's a clustered activity. So all of these connections between the professionals also help us with that. Okay, just the key, a small technical problem, because the PowerPoint it's not working now. Just 1 minute.
Okay. Technical problems, like always.
Because this presentation is very heavy, so.
I will try to. We'll try to refresh. Just a moment, okay? Just a moment. Sorry, Rick.
Just give us like 2 minutes.
It's
No problem.
technical problems.
Maybe in the meantime we can combine it with the first question from the panel
Yes,
from the
you can
audience.
ask the question until we will open that. So you can start asking some questions and then we'll answer if you want.
Yes, first question from Jamie, I think is pronounced. Where have you found the least resistance to implement value-based healthcare projects?
The least?
Yeah.
I can answer that question. First, the ones that already had previous education on value-based healthcare, people that are high committed to know their results, and people who want to publish. For example, there's a tricky point. For example, oncologists are very high register stakeholders, but then the pathway that they are dealing, it's highly complex. So yeah, it's great because you have multidisciplinary approach on oncology. It's great that you have all the ingredients for you to start, but then the pathway of the oncology pathology is so complex that I would not recommend you to start, if you're starting it now, recommend with oncology pathology, okay? But then people that really want to measure, people who are what we call the champions, you know, people who want to publish, people that are highly connected, but mainly I see this a lot. People that already had education on value-based healthcare and have some teaching about the model, they are much more committed to do it, you know, and that is very, very important. But then start small and think big, okay? Start very small, start measuring. That's one of the conclusions that I'm going to show you, but don't start immediately to a high complex pathology, or else it's going to be difficult for you to have results. Normally I say one patient a day is 360 patients a year. So starting slow, but having this leverage approach, okay? Every time that we start a new pathology, we don't have everyone on board, okay? Just be sure that this is the reality. Not everyone is believing. Now, because I have a lot of pathology, it's more easy to people to know that this can happen, okay? But it's not a normal, not a normal organization that if you're not saying you don't have this on a traditional approach, then you'll have a problem putting it in practice because people don't believe and they are afraid of being measured. They are afraid of getting the results done. So this is a perspective that sometimes is difficult, but work with the ones that really want to be with you and not the ones that say that they want to be, okay? So I already have the presentation. I'll continue, okay, to share the screen. Sorry, it's just technical problems. Okay, Pedro.
Okay, so we're just back and I will continue with prompts because, you know, prompts are really one of the most important source of data that you can have, because they are really the patient's voice. And in reality, this is the image, the patient voice is the image of what we are really doing. So we should really concentrate on this. I already talked a bit about the distribution of outcomes, but of course, apart from the clinical outcomes that we talked, the prompts should always be there. So they represent up to 60% of the importance. So when you build your standard set, you should always include at least 50–60% of prompts there. I won't really deep dive into this part. What I really want to show you is why prompts are important. Even so, this is really talked a lot and a lot of presentations. We should always remember this because they really measures what matters to patients. And also, because they can identify results and trends over time. So it's easy to compare the results of one patient in one moment and then in the other, for example, after a surgery. And also because it increases the engagement of either the patient and the doctor. So in the future, the prompts can also help with shared decision making, and that's why they are really important. Don't forget that to get a prompt, there's a lot of work there, a lot of validation work, the translation, the diversion construction, the p-values, the Cronbach, internal consistency, etc. So this is really a very work that started way long before using that prompt. And this is one image of the platform that we use in Luz Saúde. We have our own platform of prompts that directly allows the patients to fill that the prompt on smartphone or in the computer and to see the result they got, and that somehow just gathers the informed consent and also allows for the patient to be remembered that now you have to fill that prompt. And this is really a tool that we use a lot, and that's really important for this data collection. Also, we have these cards, these scorecards that also allow the patient to register, for example, pain. In this case, it's oncology, register pain, tiredness, how are they feeling in that day. And this is also a great source of data. So also to use the digital health and smartphones to get some important data for your analysis. And these are some of the results that we got. For example, here we have the evolution of the HUS for hip surgery during all these 6 years evaluation. So we evaluate this until 5 years. Also for pain in hip and the SF12 prom, and we also have the domains and the results here. And for cataract, we can also use we also use the CatQuest and can also get this data and understand even by doctor or by the baseline traits what were the result in the evolution of the patient. So to just sum all this up about prompts, don't forget that there are also evidence that indicates that reporting prompts improves the patient survival, and this was presented in ASCO in 17. So these prompts are really important, and you should never ignore prompts. And of course, all these results should be published and should be presented to the doctors and the patients so that they can act upon it and discuss the therapeutic way and what to do next. Now I will pass to Hannah, that she will talk about costs and variation.
Yes. So hello, everyone. So let's put our hands in the dough and talk a little bit about costs here. So we are going to talk a little bit our journey from cost to value. And here, just to say to you that there's something really important that we should have in mind, which is that our resources are limited and we have to find the efficiency between our processes and our costs, because somewhere between them, we will find a good way to provide better results for the patients with a certain amount of costs for those treatments. So looking for the other side or the denominator of this famous equation. Okay, so first of all, just to tell you that in Luz Saúde, we already had some business intelligence platforms available so that we can look at some dashboards and some information for managing teams and even for the clinical ones that allow us to extract some data, some raw data for us to be able to work. And the first step to look at costs for us is to look at the clinical pathways for the patients. So we pick up all of the data that is available on our system and we treat it because there's a lot of cleaning and standardization that it's needed to be done to have the information ready to work with. And we can look at something like this. And for example, here, each row represents a patient and we have the complete clinical pathway for endometriosis for each patient. So we know exactly which activities were performed by the patient in a timeline. So this is the first step when we are looking at the costs, because first of all, we need to know what patients are doing in our hospitals regarding their pathologies, of course. So looking at the costing methodology, which is really important. And here I think that all of us start thinking about how am I going to do this? Because there are a lot of possible ways of doing some costing analysis. But the most important thing is not the way you do it, but doing it. So you have to start somewhere. And the first thing, and Pedro already told you a little bit about this minutes ago, that your level maturity is really important. You have to know exactly where your company is, the kind of data you have available, the information you have available, and start to thinking about what you can do with it, because it's really important to know exactly where you are. Knowing this, you're able to do almost everything, because you just need to think in what way are you going to analyze your costs and progress from there. So here in Luz Saúde, we can extract some information, as I said before, from the system, and that information already has all the costs, direct and indirect costs, allocated for each activity for the patients. So we actually do some cleaning, some arrangement to the data, but we can have all the costs allocated for each activity, for each patient, for each pathology that we are analyzing. So we know exactly which costs are we talking about for each one of our patients regarding a specific activity or a complete clinical pathway. Something that Filipe already give a glimpse in the beginning is that value-based healthcare is many times seen as a solution to lower costs in healthcare, but honestly here, and we already said that this before, that we want value with lower costs variation and not with lower costs. So it's a bit different. And when we are analyzing costs in Luz Saúde, we start looking, for example, here for the cost variation per surgeon, and this is a specific pathology. And the thing that we are looking here is each letter is a surgeon. It's a surgical specialty, of course, and these are just the costs for this surgery, not the whole clinical pathway. And we are trying to understand if there's a big variation between doctors and a big variation within the surgery itself. And we can see, for example, that there's someone that stands out in the graph. And this is something really important because it's what allows us to give a little more specific look into this and understand if there's something that we can do regarding the specific situation. We can also look, and we always do, for the variation, the cost variation for different types of surgeries, because a patient within a clinical pathway can have more than one surgery. It can have like a main surgery and a diagnostic surgery, for example, during the clinical pathway. So we also look at this. And we don't forget the rest of the clinical pathway. So we look at all the activities and the cost variation for those activities for each patient that we are analyzing. And here we have the cost variation for surgeries, for the inpatient time, consultations, imaging, exams, blood analysis, and some urgent consultations. And looking at this and regarding specifically surgical specialties, we know that the most costs are regarding to the treatment phase. The other ones are much lower than this one. So this represents the most of the cost within the clinical pathway. Then we pick all the things up and we mix a little bit all the outcomes that we are analyzing with our costs to understand how how is their relation. And here you can see that, for example, for some scores that are analyzed for the hip patients, that if you have a greater score, your cost doesn't get higher. So we don't need to put some more expenses on the surgery to can achieve better results. So this is a really important result that we have. On the right, you can see something similar, but it's for the enhanced recovery after surgery. So if you see that you have a great compliance with that model, your cost is going to decrease. So this is also really important. And in the last graph, you can see our medium cost for patients without complications and with complications. complications. For this specific pathology, the costs go up like 33%, but there are some cases that we already seen that the costs just go to the double from the patients without complications. Then after looking at this data and regarding surgical specialties, once the higher costs are in the OR effectively, we look for each patient in each surgical episode to understand the most common material used by the patients. So this is the most costly part. So it's something that we always look at. And then we can translate this kind of information for our BIs and understand what kinds of material are being used, the percentage of utilization, which allow us to understand if it's something that's commonly used for this type of surgery or not, the quantity and the total costs to understand the representation that this has for us. Something that's really important too is the payer's information on your right, because depending on this, you will have some information if, for example, you'll have like a fee for service, or for example, like a closed package payment. Here in Portugal, at least, we have something similar to this. So this is really important for our analysis. Some other thing that we always do when analyzing these kinds of materials and looking specifically for prostheses, we are already looking for the supplier. So which is the supplier for each prosthesis that we are using, the price of that prosthesis, and the complications associated with the prosthesis. So we can have more information about all of this, because in the end, and with all of this information together, we want, and we are doing this right now, we are discussing with the teams about their results, because it's really important to give them some feedback. We are analyzing with them the outliers and acting on them every time there's a need to do that. And we can, with all of this information and their feedback, implement actual changes in processes and standardized procedures, because this is really important for lowering the cost variation and not the costs, because actually we can get higher costs if it comes with a higher patient outcome. So here are some more examples of the correlations that we are doing. We have some costs with the number of activities that is increasing. On the bottom, you have the trace fitness with the number of activities, for example, and with costs. And you know that if the trace fitness gets higher, your cost will decrease. This is something that we also have seen in our data. And for example, just to show you that Pedro told you a little bit about this too before, but we don't have like a big match between our theoretical clinical pathway with the actual one. So these are more examples that came with the same outcome. And here to tell you a little bit about these clinical pathways and some changes on them. So if we look at some already set up clinical pathway, and you have to put an extra consultation there because clinical teams says that it will improve the clinical outcomes for the patient. We can put it, of course, we can add it operationally in the process, but we need to define how to measure the results for this extra activity, monitor those results, and of course the extra costs, and in the future decide if we should keep it in long terms or not, depending on this. It also can happen that you have like a new device or a new equipment that you want to use during your surgery. And the process is really similar, but you need to do something else, because you need to understand in real world studies if the device or the equipment really performs better outcomes for the patients. And this is when these questions came out, that is like, does it show better results? Yes or no? And how it will be paid in the future. And that's where we get from price taker to price maker. And the first thing that we have to understand is that all the stakeholders in healthcare are aligned. And nowadays, I don't think that we are, we are working to get there somewhere. Here, with all of the stakeholders involved, we have to provide like an outcomes evaluation in payment methodologies and alignment between all of us, and implementing value-based healthcare models, ensuring the best outcomes for the patients in mind always. For example, looking for providers and suppliers, we have to look for procurement value-based models for pharmaceutical products and devices that gives us some evidence that the product actually improves outcomes for the patients, not just because the supplier says that it's an innovative product and it's really good to have it. We need to have the evidence that actually works before we start paying for it. So we have to find a way to do this with them, and also with payers, because if we are implementing some new technologies or some new devices that are more expensive, and we have evidence that those things really improve our patients' outcomes in the end of the day, we have to do some contracting within value-based healthcare models to guarantee that these kind of outcomes are going to be paid. Here, just to show you a little bit, because we also know that there are a lot of models for contracting nowadays, and we all want to be there, but we have like a pathway to go through before to get there, and we have to think a little bit that where I am now and where I want to be, and what conditions do I have right now to do something. I don't need to be on the top of that pyramid to start implementing value-based healthcare. It's a long way, but we can go step by step until we reach the top. Here are some more pricing models, mainly some that we have seen before. And just to end up the costs part, just to say that the risk management that Pedro already told you a little bit about before is really important. Not in the beginning of value-based healthcare models or in the beginning of the contracting models, but you have to start thinking that you will have in the future to start producing some risk management adjustments techniques to implement in your models somewhere in the future. You can start with some focus on specific patient groups, but you will have to improve it along the way while improving your value-based contracting models.
So just to finish and to answer some questions very quickly, mainly you have to know what's the cost of the acts that you are having. So for us, it's very important. The essence of strategy is choosing what not to do, because sometimes you have a big problem. So just to sum up, people are worried about the cost of a bad treatment. I'm much more worried about the cost of a bad system. And I'm worried about uncertainty of outcomes. I'm worried about lack of transparency. I'm worried about the lack of the value-based healthcare vision among this stakeholder approach. We have a lot of tools, but always remember that a fool with a tool is still a fool. So you could have the best instruments that you have, but you don't know how to use it. That's a problem. Real world data is there. A patient-centric approach is there, but you need to know how to do it, how to put it in practice. I know that I'm not sharing the screen, sorry. I will share it now. But it's mandatory and it's important for you to know that knowledge is an investment, and you should know that learning is important for you to achieve better outcomes. That's what we do. We take the teams to a simulation center. We train them the pathways, the clinical pathways. We train them the clinical new protocols. We predict what's the possible outcomes when we are introducing new ways of technology or devices. And we use this kind of methodology not to train on real patients, but to train on an environment. So take home messages, start small, think big. The optimal route, it's possible, but think about the actual practice, okay? What are you really doing? How can we improve? And remember about the burden versus the efficiency. Normally, your clinicians don't want extra burden. You want data, but you need to create efficiency on the resources that you have. Transparency is mandatory. If you don't have transparency along the chain, it will never happen. No one is engaged, no one is there with you. And the three rules: measure, measure, and then measure. Not stopping measuring. And knowledge is a tool, not a weapon. So clinical and management should talk the same language. It's mandatory. If you don't talk the same language, it won't happen. And I would really would like you to say, read chapter 5 of It Takes 5 to Tango with Verena Volter. It really brings a very important subject concerning negotiation, about the 7 steps. It's an amazing job, amazing book that has this amazing chapter that talks in a very important perspective, because you will always have to negotiate externally, internally, with your physicians, with the data that you have. And remember, not fake it until you make it, train it until you make it. And but beware, don't do this if you don't have the tools, and if you don't have the team, and if you don't have the knowledge to do it, because you will break the organization. This is not an easy point. This is not easy. So you have to have alignment of the ecosystem. Don't predict the conclusion. Use a research methodology mentality. Okay, look to the results. Celebrate small victories, please. Learn from your mistakes. It's mandatory. And don't accept magical solutions that everyone and every day is selling as the holy grail. This is not easy. That's why I always bring the child. This is the like I said, the key performance indicators. You have to keep you have to keep people interested, informed, involved, inspired. Simulation is mandatory. Theory and practice are hands by hands, because you need effective functional teams. You need very good communication. And this is not a classic concert, like a theoretical, or not a rock concert. Please play it like a jazz, okay? You should really align everyone, and everyone should have their role. And that's for you to sail safely. Please create your organizational culture of change. Create and give time to have knowledge. Measure outcomes that matters to patient with the correct costs. Create a culture of transparency. Look to the data as being your gold and an important way of structure, but start well from the beginning. That's why I always take the kids. The kids are the more honest people in the world. So this takes time. And be bold and brave to put it in practice, okay? Get on your feet. You will be going down on the earth a lot of time, and be prepared to be misunderstood. You know, this is not easy to do, but I always treat everyone with respect. This is a mandatory thing. You know, everyone should have their opinion about the subject. Always remember who is behind the wheel. It's our mission to be patient-centric approach. This is the magical of thinking big. And if you want to go fast, go alone. If you want to go far, go together. That's our purpose of putting value-based healthcare in practice. Thank you. Now we are open to question. This is our methodology, our experience. I hope it could be insightful for all of you. Thank you, Rick.
Thank you. Thank you for this very nice and insightful presentation. We indeed received some questions. The first question is, so in Canada, data is hard to get and disorganized in different IT systems. So how did you capture your data, and do you have any tips for public healthcare systems that still work in silos?
Yeah, that's a good thing. I can start telling the experience that we have, but you should start. Of course, now we have very developed model of business intelligence, but you can start by paper and pencil. You know, don't stop just because you don't have the technology. Okay, you can have a bottom-up approach internally in your service by the pathology that a few people want to measure. But start, you know, start on your Excel, start with 5 outcomes with the correct costs. I remember that measuring only outcomes is not doing value-based healthcare. Doing value-based healthcare is measuring outcomes and costs for the full cycle of care. This is very important. You cannot take conclusions just by looking to the outcomes or just by looking to costs. or else you create this correlation of view, or else you will not get any conclusions. So of course it's very silo, but you have to change slowly, and you have to pick it up the results. And you sometimes a lot of times you have guys that want to publish. So start with the database that you have, start showing the evidence and not the perception of things that are happening. And this will change and lead the way that you are able of changing progressively organization with evidence. When you come with evidence, it's a different talk, it's a different perspective, it's a different way of changing the way that people are committed to the register. People are used to register on open field. People are not used to go by structured data, but they need to have a double loop. If they have the feedback of what they are putting inside, they will be much more connected, you know, and this is very, very different. Okay. So
yeah,
that's the comment that we have, and we have on public system this working. So for us, it's not an ideology, you know. This is the purpose. Value-based healthcare is not a theoretical model. For us, it's our way of living. It's our way that we believe healthcare should be. That's why we help each other, and that's why we talk with everyone, which is public, private. This is a model that has to be in every healthcare system. It should be mandatory.
Mm-hmm. And then another question, in this case, it's from Magda. We all know that clinical shortages are a big problem, and there are not enough doctors, nurses, and other staffs to attend to all patients, and definitely not enough money to pay for all these services. So how do we start thinking about value-based healthcare and this change management in such an environment that we are currently in?
I can answer that if I know what's to or Pedro. But the thing is, the resources are limited. That's the principle of economy. The way that you can create the most efficiency with the resource that you have is something that you have to know the evidence. So you can reallocate the resources that you have with the most experience and most efficiency. But you should know one thing: not everyone should be doing everything. The thing is that you are not aligning the full potential of the resources on your value chain. I don't know if I have less resources human. I know that I have a lot of inefficiency in a process that can have high improvement. So if you pick up the resources that you have, if they are human, if they are material, if they are infrastructure, and you create the really vision of a value chain of the maximum efficiency, probably the resources are enough. What they are doing is that they are doing a lot of things with lower value. That's the point. So pick it up and see what's the higher value that you can contribute on each of the pathology with the resource that you're creating. And then allocate the activity and then the time to create the most efficiency with the resources that you have, to create better outcomes for the patient and the value chain. If you're not analyzing the two perspectives, if you're not creating the two perspective on the approach, you're just putting money to the resources that you have without knowing the output of their resources. So allocate the resources, bringing better outcomes for the patient, contribute to a better value chain and a more efficient way. I remember that Porto described in 1985 on not on healthcare in other services, and he improved dramatically the way that he was delivering the margin, what now we call value.
Perfect. And then maybe one last question is the one from myself, and that's I think you already touched upon it in your presentation a bit, but like very concretely, we in healthcare, you have like these predefined care pathways, but obviously doctors also need some flexibility in decision making because every patient is unique. So my question is, with this in mind, how do you prevent variation in care delivery and outcomes in some extent to prevent that we have very differences in variations in outcomes between, for example, mortality rates between the same or in between the same hospital, for example?
Yeah. First, with evidence, knowing what's the percentage of variance, knowing what's the outcomes and what's the variation of outcomes and costs. only when you start looking to the variation and not to the medium costs or the medium outcome, but the variation along the chain with the different actors, then you can work with them to reduce operationally the variation of the behavior with a correct correlation on the outcomes. That's something magical, you know. Value-based healthcare brings a magical thing. If you create the decrease of variation on the behavior and the expectations of better outcomes, you will reduce the variation of costs. And like we didn't say that we are the reduction of costs, because our results, as we show you, for us to get better outcomes, we don't need to increase costs, because that's another lie that people told. If you have any system that has lower in diagnosis, for you to achieve better value, you have to increase the costs for you to have better staging, better diagnosis, for you to improve your value. So you're not decreasing the costs. You have to elevate the costs for you to achieve better outcomes. What you want to do is to reduce the variability of the behavior and the variability of costs. That will lead to a very low reduction, will lead to a reduction of the outcomes. And that's when you get a more efficient value chain. And this is not about perception. This is about the evidence that we have been working over the last decade, you know. With results, we can talk about the evidence. With perceptions, we can just talk about rule of thumb, sailing, not saving really troubled waters, because value-based healthcare, this is not made for amateurs, you know. This creates huge breaks in organizations. If people don't know what to do it, you will never catch your team, you will never catch your resources, and this will be a breakdown. And we know a lot of examples all over the world that this gave a huge breakdown. And this, for us that are worried about value-based healthcare, should be a worry internally. We should be delivering value-based healthcare for this to be a reality, not a model that everyone is talking about.
Thank you. Perfect. Thank you so much for your time, for the presentation. It was very insightful, and a lot of people in the chat agree with me. Someone said it's a mind-blowing presentation, and it was very excellent. So I will put the recording online and send it to everyone so that they can rewatch it and send it to their organization, to their managers, and to influence other people to really embrace this value-based healthcare mindset into your organization. Thank you for your time, and yeah, see you next time.
See you, Rick.
Thank you, Rick.
Thank you.
See you. Thank
Bye-bye.
you.
Thank you. Thank you, everyone.